The last speaker of the session is Dr. Bernard Lukas. He speaks about the old technique, the McCash technique.
Good afternoon.
Good afternoon.
I come from Munich and have nothing to declare. Since the Dupuytren Symposium in Miami, have there been any disruptive technologies in therapeutic concept for Dupuytren? I think no. We have collagenase, needle, limited fascectomy. Everybody knows the problems, maybe after fascectomy in higher tubiana stages. There's a loss of skin and maybe a deficiency of skin in the palm, skin closure under tension, or hematoma form may lead to infection or necrosis. And if you suture your skin under too much tension, you can get wound contracture. Solution one could be you gain skin by Z-plasties or transposition flaps. We have already heard you can make dermofascectomies, but what you never should do, put skin grafts in the palm. Solution two, in 1964 from McCash described open palm technique. Some other publications later on made only small modifications. In the original technique, the indication for McCash are higher tubiana stages. Contraindication are elderly patients with contracture of the joints and patients without compliance. He described very few complications, superficial infections, and so on. In the original paper, he makes the first incision as a convex incision in the palm, and then some other incisions. The most distal one over the pip joint. When he makes fascectomy, he never does open arthrolysis. The skin is left open, he makes a non-adhesive dressing and a compression bandage for 1 week. You see on the right side the framework, the original one, which he used as a night splint. Our personal strategy for lower tubiana stages, we do Brunner incisions or Z-plasties and very seldom open palm. For higher stages, we do another skin incision, we do rectangular skin flaps and plan homodigital flaps from the middle phalanx to put over the palmar open pip joint. Then we close from distal to proximal, and if there is too much tension, the skin in the palm is left open. Surgery step by step. We sign the skin flaps as a primary situation. We do fascectomy. We switch the flaps over. Sometimes it's necessary to put a skin graft over the donor side on the middle phalanx ulna, on the ulnar side. Another possibility would be a Bailop flap from the dorsal side. Then the suture is done from distal to proximal and the skin left open. Whenever possible, I try to put some fat, local fat, over the tendon and digital nerves. The aftercare, dressing with oily gauze, night splint. We start immediately hand therapy after surgery and later on scar therapy after the finished wound closure. We did about 80 cases in the last decade with few complications, some infections which healed, which healed conservatively. We had some scarring without healing potential, which needed local debridement. And we had some patients with hypergranulation, which was treated by silver nitrate. case, 40 years old right-handed man, physicist, recurrent Dupuytren on the middle finger. We did fascectomy, homodigital flap from the middle phalanx over the pip joint, skin graft for the donor side. 3 weeks later, he had superficial necrosis, but full stride finger, full flexion, and 2 months later, nearly complete function. Same patient, 6 months later, the other side, tubiano 3 on 3 fingers. We did the same procedure, fascectomy, homodigital flaps on the 3rd, on the 4th finger, so-called Jacobson flap on the 5th finger, open palm. The first time, the open palm and the finger looks not very aesthetic. There's some webbing skin, then 10 days later, a lot of fibrin in the wound, but 20 days later and later on, the wound gets very small. The fingers are clearly without any necrosis. And 8 months later, both hands, good function, normal sensibility. He has some scarring, maybe also new Dupuytren, but he is very happy and doesn't want any other procedure at the moment. As summary, the open palm technique is a useful tool in severe Dupuytren's disease with few complications. It can be combined with local skin flaps and skin grafts. Patient satisfaction rate is high. Thank you.
Thank you. I have a question, just one, because we have run out the time. No? No question? Thank you. Sorry.
One question.
One.
What is the advantage of the flaps in the fingers compared to just leaving them open as in the original description?
I don't know. We make it because it's our technique, and I think the healing is a little bit without any problem. And the patient don't. If they see all the open wounds, the compliance must be very high.
An open wound in the palm.
Yeah, in the palm, and if you see the other on the fingers, I think it's a little bit tricky.
Okay, thank you very much.